to today's lecture of our surgical lecture series. Thank you for joining. So my name is Julie Samouri. I'm a final year medical student at AUB, and I hold the position of founding vice president of the Women in Surgery Interest Group Lebanese chapter, as well as the Association of Women Surgeon AUB. I'd like to set a few rules I'm sure you know from the previous lectures, just before we introduce our speaker and we start the lecture. So as you know, I'd like for you guys to interact with the speaker, but however, you may ask questions on the chat, and our speaker will answer them at the end. Mute yourself for the totality of the session, and so make sure your microphones are off. And as I said, write your questions in the chat box, and our speaker will be ready to answer them at the end of the question, and most importantly, enjoy. So I'll start by introducing our speaker. She is no other than Dr. Eman Sbaity, surgical oncologist at the Department of Surgery at the American University of Beirut. So she is our regional advisor for the Women in Surgery Interest Group Lebanon chapter, and she's been supporting us from the beginning. And Dr. Sbaity received her medical degree from BAU before joining AUBMC for a surgical residency, after which she completed 2 fellowships in the US. She first did a breast surgical fellowship at Johns Hopkins Hospital, and then she moved on to do a second fellowship in surgical oncology at Memorial Sloan Kettering Cancer Center, so MSK as you may know it, in New York. Today's lecture is going to be on the surgical treatment of breast cancer, and now I'll leave the floor to Dr. Sbaity to present her speech.
Thank you for this nice introduction. Thank you for this nice introduction, and I'm really glad to be participating in this event today, and I'm glad that you managed to launch this initiative, which I think will be of paramount impact on medical students in Lebanon and in the region, especially females who are interested in surgery. And of course, your colleagues, the man who will be supporting you now and forward in your careers, hopefully. Okay, and I'm going to start now by sharing my PowerPoint presentation, and we're going to talk today about overview of breast cancer surgery. A lot of advances have happened in this field, and we're going to tackle and go over the highlights. A lot of science will be presented because we need to know the science, not only know the technique, and we'll try to explore all the potential treatments available for these patients, because breast cancer has evolved significantly over the past decade and a half. It's perhaps you will, as you get to learn more pathologies, you will learn and understand that really breast cancer is on top of advancement, and a long way happened in terms of curing those patients, and more importantly, working on improving their quality of life. So there's diversity of surgical options that are not only geared to cure those patients, but also to we select the surgical option in a smart way to improve their quality of life too. So in this presentation, we're going to go over the evolution that happened in surgery for breast. And I always tell the students, think of breast surgery as surgery that you do for the primary breast tumor in the breast, and another surgery that you do to stage the axillary lymph nodes. So we're going to go over the evolution that happened in both areas. And then we're going to move to a very important chapter happening in breast cancer, which is neoadjuvant chemotherapy. As you know, it's giving the systemic therapy ahead of the surgical treatment and then going to the surgical treatment. That has a lot of advantages, but also has left us with lots of dilemmas and complexities in treating those patients. As you know, breast cancer is the most common cancer affecting females globally, and um, and 25% of all invasive cancers in women, if you think of all organs. However, this is a very important slide. We cannot talk about breast cancer as one disease. It's a heterogeneous disease with variations, and not only in its histologic presentation, the ones that you know as ductal or lobular, as invasive ductal or in situ ductal. Not only this, but it is also genomic composition differs between different individuals. So those of you, the more you read about breast cancer and the literature in it, you will notice that you cannot refer to it as breast cancer. You have to specify its subtypes that we will mention briefly. So the one size fits all approach to cancer management does not hold true anymore. We cannot do it in this day and age. There's a lot of information coming, not only from the stage and the grade. This was how breast cancer was treated. This is not enough anymore. We need to get all the criteria about the tumor characteristic from the hormone receptor. What's the status of the ER? What's the status of the PR receptors and the HER2 receptor? What's the proliferation rate? And so on. And that started in 2000 with the publication in Nature talking about subtypes of breast cancer. And the formal adoption of these different subtypes to guide treatments happened in 2013 in a very famous international meeting. And the four subtypes are displayed here in a brief. You have the luminal types A and B, which are the better prognosis, and they are usually ER positive. And then we move to the HER2 positive, where you have the HER2 gene is overexpressed, and usually they are poor prognosis tumors. However, now we have targeted therapy directed towards those tumors, and it's giving them good results. And we have the triple negative, where all receptors are negative. The estrogen, the progesterone, and the HER2 are all negative. Why is it important to talk about this? Because as prognosis differs, the way we think of treating those patients also differs. Not only we have variety in subtypes, but also a lot of systemic therapy are now in the interplay of these patients, and very effective systemic therapy. We start with the modern chemotherapies, which now they are the anthracycline based and taxane based, and they are usually polychemotherapy. So a combination of 3 chemotherapeutic agents are usually given at a time, and that has been proven really to be effective in preventing and decreasing the risk of metastasis, and thus improving survival of these patients. And not only this, and important for us as surgeons, that it also helped in decreasing the local recurrence. And there are famous adjuvant trials conducted by the NSABP groups, B13, B19, were very clear about those conclusions. And that will be, again, a change, because if I have a treatment that helps me to decrease local recurrence, then perhaps I don't need always to go for aggressive, wide, total mastectomies for those patients. Perhaps I can offer them something less extensive. Also, introduction of treatment targeted towards the hormonal positive tumors with anti-estrogen like tamoxifen. And that's why we need to understand that we cannot treat breast cancer as one cancer. So if you have an AR positive patient and you give them this very effective treatment of tamoxifen, which is prescribed for 5 years, it is now known that it will decrease recurrences by almost half, and the mortality over the first 15 years after diagnosis will be decreased by 1/3, and that's significant. Again, the HER2 positive that I mentioned are poor prognosis. A very effective treatment was introduced and became standard of care in 2005, which is called trastuzumab, and also it drops disease recurrence events by half. So that's also impressive. With all this I mentioned, you can imagine the dilemma that we face whenever we need to treat any breast cancer patient. So physicians treating cancer have struggled to strike a balance between efficacy and quality of life. And nowhere the struggle has been more controversial than in the treatment of breast cancer. I like this statement because, as you can see, it's dated 1990. And today, 30 years later, this statement still holds true. The modern surgery for breast cancer started in 1882 with the publications that came from Dr. Halsted at Johns Hopkins, where he did what we all know as the Halsted radical mastectomy. Everything is taken out, the breast, all the skin, the underlying pectoralis muscles, all lymph nodes, axillary, internal mammary, everything was taken out. However, I don't think any of you as students have seen this surgery being performed because it's obsolete now. A lot has changed since 1882. In 1972, a major advancement happened, which was the introduction of the modified radical mastectomy that I'm sure many of you have seen, and that now is a difference because now we spare a big part of the skin so that we can do primary closure. We don't remove the internal mammary nodes, we don't remove the pectoralis major, we do not remove level 3 axillary nodes, we remove only level 1 and 2. This is not enough. Since 1976, look how long back, surgeons started considering breast conserving surgery. And the first to start that was Fisher in the United States through the NSABP group, the trial B06, which they initiated recruitment in 1976. They started considering that treatment. And now we know that partial mastectomy is as equivalent to total mastectomy for treating those patients. As you can see from this table, I mentioned perhaps the famous 6 randomized trials. These are all prospective randomized controlled trials that compared mastectomy to breast conserving surgery. And when we say that, this means partial resection of the breast, partial resection of the tumor with an area of negative margins around it, together with whole breast radiation directed to all the breast. And as you can see, we have the number of patients is quite high, up to in one of those it is almost 2,000 patients, in another almost 1,000 patients. And looking at the last 2 columns, it's really impressive. If you look at the overall survival, you can see that the numbers are almost the same, 75 and 77%, 58%, so the numbers are almost the same. So we have abundance of data that reassure us if we can perform partial mastectomy, then we are giving the patient the same survival opportunity. But is it a surgery that we can offer to all patients? Not really. We can offer it to the majority, but not all. We cannot offer it if we have multicentric disease. And that means that we have disease in multiple quadrants of the breast. If we have widespread calcifications across all the breast, if we have inflammatory breast cancer, which is aggressive, advanced cancer, we cannot do partial, we have to remove all the breast. Or if the patient had prior radiation before, because as I mentioned, this type of surgery, the partial mastectomy, has to be coupled with whole breast irradiation. Okay, a lot has advanced and still more. So 1972, we started talking about modified radical, less extensive mastectomies. And now with 1991, even less extensive mastectomies with the idea of reconstruction. Why should this lady lose the whole shape of the breast? So the concept of skin sparing mastectomy was introduced, where all the skin envelope is preserved. There's the incision of the nipple and areola are removed. All the skin envelope is preserved. The whole breast is removed, and then an implant or other ways of reconstruction with tissue flaps are done, and then you reconstructed the breast. But the patient has lost her nipple and areola. So as you can see here, this is an example of these cases where you can have a normal shape of the breast, and this is an expander that has been put inside. In the beginning, the surgeons and the um, community of physicians treating breast cancer were skeptical about this modality. They were worried that because you have small incisions and not a lot of skin is being removed, perhaps the surgeon does not have enough access to all this area, cannot do a good job in removing the breast. Also, there was worry that this is a long flap. You have the blood supply coming from here and coming from here from the internal mammary. Perhaps the blood supply will not be enough to those long flaps. However, I'm going to now show you data that proves that all this skepticism is not in its place, and skin sparing mastectomy is safe and cosmetically good for those patients. So this is what was mentioned here, and they looked at the data of modified radical mastectomy versus skin sparing mastectomy, looking at local recurrence. And again, look at the numbers with me. They are almost the same. 7.6, 5.3, 0.9, 0.8. So in the same cohort of patients, the recurrence rate that happened between either modified radical or skin sparing is the same. And as you can see here, we have long follow-up reaching up to 100 months. So that's good enough, and skin sparing mastectomy is safe. Furthermore, those ladies lost their nipple and areola. Do surgeons started thinking, can we preserve the nipple and areola? And this is what we are doing. And this has been happening in the world since at least 20 years. And nipple sparing mastectomy is important because there is psychological importance for those women to preserve the nipple. They look at this nipple at the signature of the breast. They feel mutilated without it. And the other important thing is that it is difficult to reconstruct the nipple, and this is known from the plastic surgery literature, where plastic surgeons by themselves report poor cosmetic outcomes from nipple reconstruction. But we always have to think of oncology. Is it safe to leave the nipple? Like, we all have this idea in our mind that all ducts of the breast reach to the nipple, and that was the argument. All ducts reach to the nipple. Cancers arise from the ducts. So how can you leave the nipple? Because if the cancer is arising from any duct, theoretically, it should be reaching to the nipple. However, this is not true, even on theory basis, because breast cancer on histology level originates from what we refer to as a terminal duct lobular unit. And guess what? It's rarely present in nipples. So, and we know from reports on location of breast cancer, most commonly breast cancer happens in the upper outer quadrant, and it is rare to happen in the nipple. Great, this is on theory. Let's see on real ground what happened. We're always interested in clinical outcomes. I'm looking at this data. These are series that looked on reported their series on nipple sparing mastectomy, and they looked at local regional recurrence and whether the local recurrence happened in the nipple or not. As you can see, I have reported here a few of the trials. Decent sample sizes you have here up to 600, and local regional recurrences are quite low, and they resemble what we know about breast cancer. And as you can see here, rarely you have a recurrence that happens in the nipple. This is another set of studies, and you can see the largest series was reported in 2009 by Petit et al. From the European Institute of Milan, and they have 1,000 patients, and the local regional recurrence was 14%, and guess what? None of them is in the nipple areola complex. So this all speaks about the safety of doing nipple sparing mastectomy, which is important for those patients. What about data on, we talked about local recurrence, but in cancer outcomes, whenever we're talking about any procedure for cancer, we think as surgeons, of course, we're interested in local recurrence, in regional recurrence, which is nodal recurrence. but also we're interested in survival. And here, as you can see, we know that, sorry, I'm getting a message on my screen saying that the meeting is unlocked. Is there anything I need to do?
No, doctor. Some people are trying to
To
attend,
enter? Okay, I see.
uh, but they're in the waiting room. Don't worry.
Okay. So survival data, as you can see, is also always important, because it's not enough for the disease not to recur. I have also to prove that it's not affecting the life of the procedure. The less extensive procedure I'm picking is not affecting the life of the patient. And as you can see here, we can show we have a group of nipple sparing mastectomy and a group of patients who underwent skin sparing mastectomy, and they were matched based on stage, which is very important. This is how we define breast cancer, based on stage. After matching this cohort based on stage, as you can see, the line, the graph almost coincides. So there's no difference in terms of local recurrent free survival or overall survival between both.
Okay. For type 1, there are many causes. يا ان الجسم انه يشوف البنكرياس as a foreign body ويروح يهاجمه for destruction of the
Okay, so now we know that nipple sparing is safe, but we have to make sure that we properly select those patients. We cannot do it if we have suspicion of nipple involvement as obvious, or nipple discharge, again, inflammatory breast cancer, Paget disease because it involves the nipple, and if the tumor is very close to the nipple areola complex, and there is this ambiguity, what is close? That's why I have two question marks. So traditionally they say less than 2 centimeters. Now we accept less than 1 centimeter without any radiologic evidence of disease. This is an example. I want to show you how good this technique can be. Looking at this image, I could say this patient does not have surgery, but a side profile, the patient has surgery, and this is the incision where the lateral inframammary incision where the whole breast was removed. And this is actually one of our patients, and this is on the other breast, and the plastic surgeon has done a very nice job reconstructing the breast. So this is the outcome. So a mastectomy doesn't have to be mutilating. We have these new techniques that we can offer to the patient in collaboration with the plastic surgeon to provide them with good cosmetic outcome. However, complications, we have always to remember complications can happen in surgery. And specific to the nipple sparing mastectomy technique, you can have, as you can see here, a nipple necrosis. And the main risks, if the patient gets the radiation early, large breast, also what type of incision, like this is not a good incision to do because it is cutting in the areola. We usually prefer incisions that do not touch the areola. They are away. And always remember, whenever you're choosing the surgery for the breast, we have to make the balance between an excessive resection that is unnecessary, mutilating, but you cannot also underestimate the importance of complete clearance of the breast cancer and do something that is less adequate. As I mentioned, we also need now to move to think, what type of surgery shall I do for the axilla? As I mentioned, they used to remove all internal mammary lymph nodes. Now we don't do that anymore. And a new concept came to cancer surgery, which is sentinel lymph node biopsy, introduced to other diseases. The last was melanoma. And then following that, we started introducing it in breast cancer surgery. And that was done first in 1997 by Armando Giuliano. And he's very famous for that procedure. And this is a sentinel lymph node biopsy. A dye is injected in the breast, in the operating room. It moves, the dye moves in the lymphatic channels and reaches the sentinel lymph nodes, which we define as the first sentinel lymph nodes of the axillary lymph node basin draining the breast. And as you can see, we remove them out and we test them. And they are tested in slices of 2 millimeter, very close sectioning. And if we find cancer inside them, it can be either an isolated tumor cell, which is very tiny disease, or can be a big macrometastasis defined as tumor more than 2 millimeters. Anything in between is defined as micrometastasis. This is very important because it has implications on treatment whenever we're considering this complex decision making about what type of surgery shall we do. This is just showing you pathology slides of an isolated tumor cell, and this is here a big deposit. In the past, they used to do axillary lymph node dissection, as I mentioned, with a modified radical, and still we practice it, but very infrequently. The standard of care is sentinel lymph node biopsy. And the concept is, the premise of sentinel lymph node is, if the sentinel is negative, and because it is the first lymph node in the chain, so we believe that the rest of the lymph nodes are also negative. And this is not only by theory, but it has been proven. And as you can see here, I mentioned the famous 3 randomized trial by Veronese, by Craig et al. That did a randomized multi-center validation trial, and they proved that it is okay to use sentinel. And this is the example of the NSABP B32, the famous one, 4,000 patients. They randomized 2,000. All 4,000 had negative sentinel lymph node, and they randomized them 2,000 to just sentinel, nothing more, and the other 2,000, they did the sentinel negative and followed it with axillary dissection. And look at their overall survival curves. Amazing. They are just, at 8-year follow-up, they are just aligned. No difference whatsoever. If sentinel is negative, please do not do anything further. No need for axillary dissection. The same with disease-free survival, meaning no increased local or regional recurrences. And if we can offer the patient sentinel, we are sparing her all the morbidity that comes with axillary lymph node dissection. Most importantly, that you may know about is lymphedema. As you can see here, the right arm has lymphedema and sensory morbidity that happens in the inner aspect of the upper arm. So now, as of 2005, there was a very clear statement from the American Society of Clinical Oncology, ASCO. This is a popular and very impactful body that sets guidelines of our practice as medical oncologists and surgical oncologists. As of 2005, if a sentinel lymph node is negative, there is no justification to do any further axillary dissection. And here I would like to mention that, sad enough, in our in Lebanon, and also I'm aware that also in the regional countries, because when we go and lecture and we know the surgeons there, in Lebanon and regional countries nearby, not everybody is doing sentinel. Still, patients with early breast cancer, node negative, they are still doing for them sentinel lymph node biopsy, and that's not really correct. Axillary lymph node dissection. Axillary lymph nodes in early breast cancer should be evaluated with sentinel, not dissection. You do axillary lymph node dissection if you have enlarged lymph nodes, palpable, if you prove that they are positive by FNA or PET scan. If a sentinel is negative, no further axillary dissection. If a sentinel is positive, the historical teaching was you go for axillary lymph node dissection. However, even this has been challenged, and there was authors all over the world reported small series of patients on the average of maybe less than 100 or 200 patients where they had a positive sentinel, but they were properly selected and they did not do for them axillary lymph node dissection. And guess what? They followed them for over 30 months and there was no axillary recurrences. So people started thinking, do I really need to do dissection for every patient with positive sentinel? If any of you have seen a patient with a lymphedema in her arm, you understand the frustration and limitation that she has to live with all her life. Remember, those patients are receiving excellent systemic therapies that are impactful, and they are living long survival. These patients, as you may have heard, breast cancer patients don't usually die from breast cancer most of the time. They die from something else, other diseases. So it is important for us to make sure we don't leave them with a limitation and in their arm. That's why we are trying. The Surgical Society has been always pushing to sway away from axillary dissection. Is axillary lymph node necessary for every patient with positive sentinel? We used to do axillary dissection because It is important, prevents recurrences. It tells us if we need to give chemotherapy or not. However, most of these don't hold true anymore. And now we are getting the information from other parameters like the type of the cancer, as I showed you, the molecular subtypes, and also if you have heard of Oncotype DX, for example, multi-gene testing. We send the whole tumor for gene testing, and that tells us if they need further therapies, whether it is hormonal or chemo or so on, or Herceptin. So really the lymph nodes are not giving us a lot of information anymore. Moreover, even those, we know that the false negative rate of sentinel is on the average of 5 to 10%. However, we don't see a lot of local recurrences after neoadjuvant, and this is what Veronese named as recurrence gap. You have high false negative of 10%, but barely 0.25% of nodal recurrences after sentinel. So not every positive lymph node need to do dissection. This is in theory. Let's see what survival data showed us, because this is what matters. As I'm always telling you, we need data. And this is a famous trial which was conducted by one of the breast cancer groups in 9 countries, 27 centers, and they had both, they had patients who had micrometastasis in the sentinel. Remember the one that I showed you between 0.2 and less than 2 millimeter. They randomized those micrometastases, positive sentinel micromets, to no dissection versus dissection, and look at the numbers, disease-free survival, meaning what is the nodal recurrence and the local recurrence in the breast. Same numbers. There is no advantage to doing axillary dissection if you have micrometastases in the lymph nodes. This is another piece of data showing the same. Here they have also 18 different centers, and when they looked at the curve of disease-free survival between same patients, they have positive micrometastasis. One arm was randomized to dissection, the other to no dissection. Look at the curves, disease-free survival, it is the same. So there's no role whatsoever for axillary dissection, and this is what we all practice. Micro disease, you don't need to do dissection. What about if we have a positive sentinel with macro disease? You would assume that maybe we need to do dissection. Again, this is even this is challenged. And I'm gonna show you the famous randomized trial that was done. Those of you students who went with me to the operating room, I'm always mentioning this, talking about it. And this is the famous Z11 trial, many centers in the United States. And what they did is they took those patients, and again, they had those that had sentinel lymph node positive, and they randomized them to axillary lymph node dissection versus no axillary lymph node dissection, and they looked at the follow-up. Very important here to mention that those patients had their tumors less than 5 centimeters. That was the eligibility criteria. Whenever you're reading an article, please look at the eligibility criteria to see how can you apply it to your patient. So T1 or T2 less than 5 centimeters, they had to have a partial mastectomy, not a mastectomy, because with partial mastectomy, we get whole breast irradiation. So this will allow them, so that's a very important eligibility criteria. And when we mentioned all those, they didn't have to have neoadjuvant chemotherapy. And when they looked at the numbers, again, local regional recurrences, they were all similar, no significant difference between both arms. And this is, remind you, macrometastasis, tumor more than 2 millimeters. And this is looking at the disease-free survival and overall survival of this cohort of patients at 10-year follow-up. No difference whatsoever. The condition here is those patients had only 2 or less positive lymph nodes. So if I have a patient with tumor less than 5 centimeters, partial mastectomy, I do a sentinel, only 2 positive lymph nodes or 1 positive lymph node, I don't need to do dissection, whether it is macrometastasis or micrometastasis. Partial. Now, what about doing it for mastectomy? So this is the advance. First, we proved it for partial with whole breast radiation. Now we move to prove it for mastectomy. And this is a very nice study, the Amaros trial. Similar concept, they randomized, same concept. Patients with node positive, they randomized them to axillary dissection versus no axillary dissection. Again, look at the curves. disease-free, overall survival, it's the same. So there is no value for doing at 10 years, the axillary recurrence was the same between both arms. So no value of doing axillary dissection and giving the patient all the morbidity of axillary lymph node dissection. Eventually, in 2019, the NCCN guidelines put it clean and clear for all what we mentioned now. And the take-home messages here from this section, before we move to surgery after neoadjuvant, is that if you have node negative, no need for axillary lymph node dissection if a sentinel lymph node biopsy is negative. Sentinels, even with macrometastasis, don't always have to require an axillary dissection. Please check well the eligibility of your patients to either of the studies and apply it to them. Now, this is all the arms that all the options that we have in surgery. But now we have something new that happened in breast cancer surgery. We don't always do surgery first. Historically, surgery was done first in all cancers. But now we consider in some of those patients to do neoadjuvant chemotherapy. Specifically, those patients what we refer to as locally advanced breast cancer. And that's defined by either the tumor size is big, more than 5 centimeters, or sometimes we can go for more than 2 centimeters. And also when you have positive nodes, you need to give there is benefits for neoadjuvant chemotherapy in this situation. A big tumor that needs a mastectomy, you can downsize it and allow breast conservation. Even for smaller tumors, if it's 3 centimeters or 4 centimeters, you can even shrink it more and allow a smaller resection with partial mastectomy and better cosmetic outcomes. So if I embark on neoadjuvant, there are questions in my mind. Does downstaging this large primary tumor allowing me to do this resection, is it leaving disease behind? And if I do partial mastectomy for those patients, am I increasing their local recurrence? Again, what about the axillary lymph nodes? Can I still do sentinel after neoadjuvant the same way I do sentinel up front in node negative patients? And these are all very hot questions. Thankfully, most recently in the last 4 or 5 years, we have publication of very impactful studies that address these questions. And I'm going to go over them briefly so that you have heard about them. When we give neoadjuvant, remember, there are 2 patterns of response, either concentric, where all the tumor shrinks and there's nothing in the periphery, it's clean, or you have what we call the Swiss cheese pattern, where you have a lot of residual disease. And that's why we think maybe in some cases, if I do partial mastectomy, I may have a higher local recurrence. However, let's look at the data. Always look at the data. These are the famous neoadjuvant trials, and they looked at patients who had breast conserving surgery upfront and those who had breast conserving surgery after neoadjuvant. And look at the numbers. The local recurrence is 10%, 13%, survival rates exactly the same. And the same happened in the URTC trial. Partial mastectomies upfront compared to those after neoadjuvant, same local regional recurrences and survival. So it is safe to consider partial mastectomy after a neoadjuvant, and this has been proven more recently in a meta-analysis. How can we better select those patients for neoadjuvant? Because it is really frustrating to take patient for OR and then we see that we're not successful, positive margins, reoperation. It is frustrating. We have to have a better way to select those patients. And this nice study from Andy Anderson on 340 patients tried to answer this question. And I'm just going to show you what on multivariate analysis, what are the variables that matter. They found that nodal status, the higher nodal involvement on initial presentation, the less likely you are to be successful in partial mastectomy. Also, the larger tumor size, the less likely you are to be successful. So try to select for smaller tumors and node negative. Again, if it is multifocal disease, so you are more likely to have positive margin and not succeed, and if you have lymphovascular invasion. And these 4 parameters, we use them in our clinical practice to guide us when do we choose the patient for partial after neoadjuvant, and when we tell the patient we don't think you will be successful. please, very important, how to plan those patients. Do full imaging before neoadjuvant with mammo, ultrasound, and MRI of the breast. And then repeat all this imaging when the chemotherapy is done. Reevaluate the extent of residual disease so you can decide properly what to do. And MRI is helping us a lot. Another very, very important thing, please leave a clip marker in the primary tumor, which is something is left by that is used by the radiologist. By ultrasound, they can put for us a clip in the tumor. So when after neoadjuvant, sometimes the tumor disappears and we get a complete clinical response. Nothing on imaging. We need to know where the tumor is. We need the clip. Okay, and this is a very nice example. Look at this tumor on MRI. These are two views on MRI, and look at it after neoadjuvant. Complete disappearance. This is the same tumor as seen by ultrasound. Again, complete disappearance. That's why we need a clip. This is a graph that looked at different modalities, mammo, MRI, clinical exam, to evaluate the response of disease after neoadjuvant. So I can decide, can I do partial or not? And as you can see, the clinical exam alone is not enough. It's the pink dashed line. It's very low. And look at the red here, the MRI. It is excellent in giving us a lot of information. Now, we decided what to do with the breast surgery after neoadjuvant. Let's tackle the last few slides about what to do with the axilla. We have two scenarios. A patient who came with a negative lymph node in the axilla, but they had a large tumor, so I took them for neoadjuvant. And that's we'll discuss now. Later, we'll discuss patient came with node positive, then received chemotherapy and became node negative. Should I still do a dissection for her, or can I offer her sentinel? This is for upfront node negative. As you can see, multiplicity of studies, all those. Look at the false negative rate, very low. Look at the accuracy of the sentinel, very high, up to 100%. So I do axillary dissection for those patients and give them all the morbidity. Please do for those patients sentinel, even after neoadjuvant. And this is a meta-analysis. As you can see, all those studies, identification rate very high, 95%, false negative rate very low, 7%, accuracy very high, 99%. So we can offer it after neoadjuvant. What about those who were positive and switched to negative? These are my last few slides. We know that across many studies, they tell us that the response rate in the node is 40%. So a patient coming to you with node positive, giving her chemotherapy, you expect 40%, 4 out of 10 will become node negative. So you can save these 4 patients out of 10, lifelong morbidity of axillary dissection. What does the literature tell us? Again, multiplicity of data. Look at it. We have reasonable false negative rate, a little bit higher than the ones I showed you before, as low as 5% or high as 14%. So we are considering sentinel lymph node after neoadjuvant for those patients. But I'm gonna, these are here, look at the number, as we were saying, identification 90%. This is the meta-analysis. False negative across all studies is 13%, a bit higher than we would like, but still reasonable. And pathologic complete response across all studies, 40%. So how can we choose those patients? When can I offer sentinel if a patient turned to node negative? I'm going to show you this one here. Look at this graph. This tells us all the story. They noticed that when you retrieve more than 2 sentinel lymph nodes, the false negative rate dropped significantly. It's 5%, as opposed to if you retrieve only 1, 18%. Again, don't do one method of sentinel lymph nodes. Do both methods, the radioactive tracer and the blue dye. Again, false negative rate with dual technique dropped to 5% from 16% with the one method alone. And this is what we do. If I have those patients who converted to node negative, I take them to the operating room, perform both techniques, and I have to retrieve more than 2 lymph nodes. If I don't retrieve 3 lymph nodes, I will abort and go to axillary dissection. As I said, dual technique and retriever of 3 lymph nodes. And this is one study that looked at survival for those who were node positive, transferred to node negative, and they did for them sentinel. and they compared them to those that they took them for axillary dissection. Again, looking at the curves, exactly the same at 60-month follow-up, meaning 5 years of follow-up. So you can offer this patient. My last 2 slides in summary about this section. If you have a patient coming to you, you do neoadjuvant. If she came with initially node negative, there's a lot of literature to do sentinel after neoadjuvant without any rules. If they are node positive and they remain node positive, no option except axillary dissection. If this node positive became node negative, then you can go with sentinel based on the conditions that I already mentioned. Dual technique and 3 lymph nodes should be identified. So in brief, we have learned together that we can do less extensive surgery and still do excellent local control, provided we do proper selection, proper evaluation of the patient, proper understanding of the disease biology, and of course, appropriate multidisciplinary coordination with the medical oncologist, with the radiation oncologist, radiologist, plastic surgeon, everybody. And of course, what does the patient want? That's very important. Because you have to give her options. There's lots of options. And thank you all for your attendance.
Thank you, Dr. Sbaity, for this amazing, honestly, presentation.
Thank you.
It was very informative, and the updated data was very useful. We'll now move to the Q&A. So we have Ahmad Ashi who's asking,
Sure.
Doctor, I always have this idea in my head. Why don't you remove the sentinel lymph node or remove the whole lymphatics in high-risk patients for breast cancer, ever if they don't have breast cancer now? I think this will prevent the Mets if they have cancer later.
Yes, Ahmad, exactly, and that's why surgeons and medical oncologists advocated for removing all the axillary lymph nodes. And I have shown you in the beginning of my presentation, the first section on sentinel, that it is not important. And I have showed you the accuracy, that's important, the accuracy of sentinel lymph node biopsy. So if you do a sentinel and it is negative, so how did they do these trials? They took patients who are breast cancer and they have negative nodes. So they took those patients and they did for them sentinel lymph node, and it was negative. Then they took those sentinel node negative and they randomized them. One arm they didn't do anything for them, and the other arm they did what we call backup axillary dissection. And they looked at the results, and they found, as I showed you, that there was not a lot of positive nodes. A very small proportion had positive nodes left behind in the axilla. So most of them had everything out. And even though they followed these who did for them only sentinel lymph node alone, and they are negative, and I showed you the famous NSABP-B32 graphs for survival. There was no difference in recurrence. Those who did not get dissection did not have any additional nodal recurrences, and the follow-up is long. So why they have follow-up over 10 and 15 years? So if I have all this data, Ahmad, why should I go and remove all these nodes? We have those patients and they never recurred in their nodes. Does that answer your question? Because the other side would be doing axillary dissection with a lot of morbidity, as I mentioned. I hope that answers your question. Any other questions? Amazing lecture. Thank you. Abdul Majid, thank you.
Okay, so if we don't have any other questions, I think we can end the session. Thank you very much again, Dr. Sbaity. Everyone's talking about the data and the analysis you made.
I hope it was, it's tough, complex. I hope I managed to simplify it and make it accessible to you guys, because honestly, it may be considered as a bit higher than your level, but we have high aspirations of you and nothing is high of your level. So hopefully you got it.
Thank you very much.
You're welcome.
We'll end this, and have a great evening, everyone, and thank you again, Dr. Sbaity.
Thank you again for inviting me. Thank you for doing this initiative. And I'm glad that I saw a lot of audience. Hopefully more and more will benefit from this lecture series.